Hello, everyone. Welcome to the Doctor Thyroid podcast with Philip James. I am your host, and today's guest is Dr. Vaninder Dhillon from Johns Hopkins. Welcome, Dr. Dhillon.
Thank you.
And today's topic is follow-up to treatment with ablation for thyroid nodules. What to expect, what to look for. Dr. Dhillon, first off, what is thyroid ablation?
So thyroid ablation is a form of minimally invasive therapy directed to the thyroid nodule. And when we commonly think of thermal ablation, we think of different types of thermal energy that we can use. The most prevalent one currently is radiofrequency ablation. So a very specific type of technology, which is radiofrequency to directly ablate the thyroid nodule in question. And that treatment, like I mentioned prior, is directed to the nodule. So it is preserving of the rest of the thyroid gland, and it is non-surgical such that we don't have to remove any portion of functioning thyroid gland, leaving the patient without their thyroid or thyroid hormone. So it's beneficial for some patients that are eligible for this type of treatment to save not only their gland, but their thyroid function.
Just for patients who are new to thyroid ablation and listening to this interview, let's just restate, if we could, that it's treating the thyroid nodule without doing surgery, correct?
Correct.
During that treatment, it's not like the thyroid nodule just disappears after one treatment.
That is
Can you explain what to expect? So can you take us through the journey of what happens to the thyroid nodule from the moment you are getting ready to treat it with ablation? And then what happens does it take weeks, months? What happens to it?
Yeah, so this is a very good question. And again, this is going to be directed towards radiofrequency ablation because, as I mentioned before, there are other types of thermal ablation and other types of technology that may have different timelines in terms of the ablative results. But when we're focusing on radiofrequency ablation and most minimally invasive therapies, we're talking about a reduction in volume of the thyroid nodule in question. So the end goal ultimately is to reduce the size and the volume of the thyroid nodule. And what that means is that we are not going to make the nodule disappear. We are not going to excise the nodule. We are going to ablate it. So the nodule will remain in the normal thyroid gland, but much smaller. So the timeline for that, it depends really when we're talking about radiofrequency ablation on the baseline volume. So that's very important when we see patients for consultation because every thyroid nodule is different in size, but we look not only at size in a linear dimension, but in a volume dimension, because a nodule by definition is not a circle, it's a sphere. So it is a multiplication of 3 dimensions, which is how most nodules are reported in terms of size. And so when we're looking at volume, we multiply those 3 dimensions as a starting baseline. So there, based upon guidelines, there have been smaller volume nodules, moderately sized volume nodules, and then larger volume nodules. So typically anything within 20 milliliter cubed or centimeter cubed is sort of within the limits of a good sized, relatively mild sized nodule with a volume that we hope with one treatment should undergo a 60 to 80% volume reduction. And what that means is that after one treatment with a nodule that is 20 centimeter cubed or less in volume to start with, it should be, let's say, 5 ml to end with in terms of volume. So that is a good size reduction, meaning that upon that volume reduction, the risk of recurrence or regrowth is pretty slim. Now, the timeline for that is variable. We have looked at a lot of data, and guidelines have been published suggesting that the best that we can expect with a 60 to 80% volume reduction should be within 6 months of the treatment. So it's not an immediate volume reduction. And unfortunately, it's not something that maybe for patients, if it's a noticeable thyroid nodule, outwardly appearance-wise may, disappear right away. But within 6 months, we're hoping that if it is, again, 20 milliliters cubed or less, we have about a 60 to 80% volume reduction based on ultrasound measurements.
So a patient comes in and they're being treated with ablation for the thyroid nodule. Thyroid nodule is benign or malignant or both?
So that's a good question. Most of the guidelines, when we discuss volume reduction, we're talking about benign nodules. I would like to highlight that within the benign nodule category, we also have a category or subcategory of autonomously functioning nodules, which is a separate category for thyroid nodules that actually has to do with hyperfunctioning thyroid nodules. So if we're talking about benign nodules in general, we're talking about patients that have no hormonal elevations because of the nodule itself. The nodule is just benign and non-functional. So that is what, in terms of volume reduction, we're hoping for benign nodules in terms of the radiofrequency of treatment. When it comes to malignant disease, the guidelines are a little bit different. Typically, we would like the same sort of volume reduction, but there is a little bit more of a goal for almost complete ablation, at least sonographically or on the ultrasound, such that we are almost unable to detect it visually, because we really want to treat typically recurrent or persistent disease. So for malignant nodules, the primary treatment is still surgery. But if a patient has recurrent disease, has undergone lots of surgery prior, or has high risk factors for undergoing another surgery, we would consider radiofrequency ablation for that patient.
And after the treatment, how soon until they come back into your office or follow up?
So in my practice, I see my patients back at 1 month, 3 months, 6 months, and a year. That is not standard of care by any means. I think the guidelines recommend that the patients be seen at least at the 6 month mark, because not only are we checking volume reduction, but we also do anticipate having to check thyroid hormone levels to make sure that there's really no change in thyroid function for the rest of the thyroid. So, anything in the in-between is really up to the provider that is doing the ablation. But I like to see my patients back typically within 1 month, because for those that have symptoms associated with their benign nodules that brought them into my practice in the first place, for example, whether it be cosmetically displeasing, they can see it on the neck, or it's unpleasant in terms of appearance, or compressive symptoms, whether they feel something like a ball in the neck when they swallow, when they're lying flat. Those symptoms usually, and again, anecdotally in my practice, they usually get better within 1 month. So I like to see my patients back at that 4-week mark. And then the 3 month mark is just to, again, measure the volume reduction on ultrasound, and then the 6 month and 12 month to complete the final evaluation of the nodule that was treated.
And you said there's a 60 to 80% reduction in volume from that first treatment. Are you having to treat a second time?
Yes, I think it depends on the baseline volume. Again, it's very important that when you are seen by a provider that will potentially offer radiofrequency ablation, that you undergo not only a formal ultrasound of your thyroid to see which nodule is going to be treated, but to actually undergo an ultrasound, I think, in the office with that provider who will be doing the treatment, because there's a certain amount of information that in-office ultrasound provides, especially the baseline volume, which can then be calculated and followed after the treatment. I think we have to look at not only the baseline volume, but anatomically the location of a nodule, which is a whole separate conversation. Is the nodule approachable and very anterior, meaning in the front of the neck? Is it posterior and deep? Is there any component that's going below the collarbone? Sometimes there are thyroid nodules that extend below the collarbone. So technically, the radiofrequency ablation is not necessarily approachable the first delivery of that treatment, because an ultrasound cannot penetrate with ultrasound waves through the bone. So we can't really visualize below collarbone, but that patient may need subsequent treatments, because we have seen sometimes the cervical portion or the neck portions retract up. And so it was originally below collarbone may after a few months come up towards the neck, and we can treat it a second time to get that full reduction. So again, there's a lot of anatomical considerations along with the baseline volume that determine whether or not a patient requires a second treatment. But I usually do that in-office ultrasound evaluation with my patients, and the conversation of whether or not they will need a second treatment or not at that initial consultation, so they're aware of that as an expectation.
Okay, great, Dr. Dhillon. We're talking about thyroid ablation, removing or treating thyroid nodules, not necessarily removing thyroid nodules, with ablation and not surgery. So now we are coming to the end of our interview, and we're going to do some rapid fire questions, if that's okay with you.
Sounds good.
Okay, so what do you think every patient right now should know about treating thyroid nodules without surgery and treating the nodules with ablation instead?
They should understand that the ablation is a good technology to shrink the nodule, to make it maybe less cosmetically displeasing, or hopefully relieve cosmetic symptoms if it's benign. And that our goal is ultimately to reduce the size of that nodule for the long run.
And what do you feel is so exciting about thyroid ablation for patients?
For the majority of patients who have benign thyroid nodules, this provides a means to preserve thyroid function, which for many is otherwise normal. It also allows patients to have the opportunity to potentially save themselves the risks of undergoing surgery or the uncertainties of the complications associated with surgery. And so it's a good alternative for patients that are seeking to direct the treatment to the nodules that they're concerned about, rather than having to live without a thyroid gland.
Okay, great. Any final thoughts before we say farewell?
No, I just want to say thank you, Philip, for the opportunity to talk about this small topic, but I think it's important because these are the questions that bring patients in, and hopefully, with a little bit of online information like this podcast and this video cast, then patients have an idea of what to expect if they come in for consultation. So I think these are the things that patients want to know, and hopefully today's session gave a little highlight into that. So thank you.
Well, thank you so much. All the links to get in touch with you will be listed in the description to this episode, including links to some information about your presentations at the ATA conference this week, which is the American Thyroid Association's big conference, and you're presenting a couple sessions. So those listening can find more information about you and your work in the description to this episode. So thank you so much.
Thank you.